Welcome back to the deep dive. This is where we take the most foundational, complex, and high-stakes knowledge in medicine and biology and really break it down until you possess the mastery of an elite professional.
And today's topic is, well, it's about as foundational as it gets.
I agree. Our focus is the incredible, absolutely essential biological process that underpins pretty much all surgical and medical success: wound healing and tissue repair.
It really is the cascade that defines recovery. I mean, whether a patient is healing from a tiny hairline incision or, recovering from a complex trauma involving bone and soft tissue,
Right.
the body's ability to execute this sequence perfectly is the ultimate measure of a successful outcome.
Exactly. And our mission today is to move beyond just the textbook definitions and really unpack that dynamic sequence, the who's involved, the when, and critically, what happens if it goes wrong.
We're diving into the microscopic symphony that transforms an open injury into a stable, if not, perfect scar.
So to get started, we have to define our starting point. What technically is a wound?
It's simple at its core. A wound is a break in the integrity of the skin epithelium, often with a concurrent disruption of the dermis underneath. It's a breach in that primary barrier.
Okay, and when do we, as clinicians, get to officially declare victory? What does healed actually mean biologically?
Healing is achieved when two things have happened. First, the connective tissue repair has to be complete. The scaffolding is built.
And second?
Second, you need complete re-epithelialization. The skin cover has been restored with scar tissue. And from a clinical standpoint, it means the wound doesn't need grains or special dressings anymore. It's stable.
That seems like such a simple endpoint, but getting there requires, what, hundreds of simultaneous molecular decisions?
Yeah.
And biology, as we know, rarely runs a perfectly clean course.
That's right. And understanding the normal process is the absolute prerequisite for treating the pathology. And that pathology really exists on a spectrum.
Okay, so on one side you have,
On one side, you have the failure to heal. The process stalls. This leads to chronic, non-healing wounds, the kind you see so often in patients with diabetes or peripheral vascular disease.
and on the other end of that spectrum, where the body's repair mechanism is maybe a little too enthusiastic.
That's the excessive or aberrant healing response. This is when you get an overproduction of all the building materials, leading to hypertrophic scarring or even more aggressive keloid disease.
So this deep dive is all about understanding that delicate balance, how to stay in the middle and avoid either extreme.
Exactly.
Okay, let's start with the big picture then. How the body physically closes a wound. I think this is a foundational concept for any kind of surgical decision-making. We talk about a wound's intention. What does that really mean?
It really just describes the clinical approach to closing the gap. And we can start with the gold standard, which is primary healing, or what's often called healing by first intention.
So what makes a wound eligible for this? What are the characteristics of an optimal wound for this kind of treatment?
You're looking for wounds that are inherently clean, well perfused with blood, and, typically result from controlled trauma. Think of a sharp surgical excision or a clean, small laceration.
The key being that the edges are viable and can be brought together easily.
Precisely. The mechanism involves that mechanical assistance sutures, staples, skin glue to approximate the edges right away.
And how quickly are we talking?
It's rapid. Closure happens within 12 to 24 hours of the injury, and the benefit of doing that is immense. You drastically reduce the distance the migrating epidermal cells have to travel.
So you're basically giving the cells a huge head start. By minimizing the distance, the body saves time and energy.
You got it. And the outcome is the fastest possible healing, which usually gives you the best cosmetic result. A fine hairline scar, because the body only had to do a minimal amount of biological bridging.
Now, what if you miss that window? Or the wound is just too big or too dirty to allow for that clean, immediate closure?
Well, that moves us to secondary healing, or healing by secondary intention.
And this happens when approximation is just not on the table.
Exactly. It's either impossible because the wound is too large, or critically, it's a bad idea because the wound is infected or heavily contaminated. In those cases, you have to leave it open and let the body do the work from the inside out.
And if the edges aren't touching, the whole mechanism has to change, right? How does the body bridge such a big defect?
Well, the initial defect has to be entirely filled with something called granulation tissue. It's a whole new biological filler. And this means the epithelial cells have to grow down the sides and then all the way across this new massive surface.
And the physical process here is defined by one key cell type we should probably highlight.
The myofibroblasts, absolutely. These specialized cells show up around day 3. They're basically fibroblasts that have differentiated and gained the ability to contract.
So they act like tiny internal drawstrings.
A perfect analogy. They literally pull the edges of the wound closer together, shrinking the final area that needs to be filled with new tissue.
But the outcome here is obviously very different. We're talking weeks, not hours.
Oh, it's a much, much slower process, and the clinical risk is a lot higher. While that contraction is necessary, if it goes too far,
You get contractures.
exactly. You get functional contractures, which can be devastating over a joint where they can severely impair range of motion, and the scar is usually broader, more irregular, and just less cosmetically pleasing.
Okay, so that brings us to the third type, delayed primary healing or tertiary intention. This sounds like a surgeon making a very calculated move.
It is. It's a critical strategic decision you use for contaminated wounds. Think of large animal bites or wounds with massive dirt and debris, or an abdomen with severe peritoneal soiling.
Because closing that immediately would just be asking for an abscess.
It's a recipe for disaster. So the contamination risk forces you to pause. The surgeon deliberately leaves the edges unopposed for a few days.
What's the biological function of that pause, that 3 to 4 day wait?
That pause gives the host's own defenses, the phagocytes, the inflammatory cells, time to flood the wound bed and destroy the majority of the contaminating bacteria and debris. Then, once the wound looks clean and vascular, usually after 3 or 4 days, the surgeon goes back in and approximates the edges.
So it's kind of the best of both worlds. You manage the infection risk, but still get a more controlled closure than you would with secondary intention.
Exactly. It's contamination management plus controlled closure.
And finally, what about superficial or partial thickness healing? This is probably the most common type of wound we all experience. Abrasions, scrapes, that kind of thing.
Right, or the donor sites for split thickness skin grafts. These injuries are limited to the epidermis and maybe the very top of the dermis, the papillary dermis. The key biological fact is that the basal cell layer of the epidermis, the source of new cells, is still at least partially intact.
So if the top layer is gone, where does the new skin come from? It's not just from the edges.
That's the crucial part. Regeneration doesn't just happen from the periphery. It comes from epithelial cells that live deep inside the dermal appendages.
The hair follicles and oil glands.
Exactly. The hair follicles and sebaceous glands. They act as these little islands of epithelial tissue deep in the dermis. So the remaining basal cells and these appendage cells all start to replicate and migrate at the same time.
So the wound heals from the edges and from dozens of little points in the middle simultaneously.
Which is why the outcome is usually very rapid, complete healing, achieved entirely by re-epithelialization, and often with minimal or even no scarring, as long as the deep dermis wasn't badly damaged.
Okay, so now we can delve into the molecular and cellular biology that actually drives all of this, the cascade itself.
Yes, this is the sequential, highly coordinated cascade that has to be executed perfectly. We're talking about phagocytosis, specifics, cytokine release, chemotaxis, and the synthesis of what we call the extracellular matrix, or ECM.
And I think it's important for you as a listener to visualize this not as 4 separate acts, but more like a heavily overlapping relay race. When you look at the timelines, phase I, hemostasis, is immediate. Phase 4, remodeling, can stretch out for months or years.
That's a great way to put it. The peak activity for each phase happens sequentially, but they are all running in parallel for long periods.
Let's start with phase I, hemostasis, the immediate response.
Phase I happens on a logarithmic timescale. It's basically instant, and it has 2 jobs: stop the bleeding and sound the chemical alarm.
The trigger is the injury itself, right?
Yeah.
It disrupts the vascular endothelium, blood spills out, extravasates, and exposes the underlying basal lamina.
Correct. The first thing that happens is endothelial cell constriction to minimize blood loss. But the key players here are the platelets. They rush into the breach, they aggregate, they activate, and then they degranulate. They release their chemical packages.
And those chemical packages are the growth factors. If we're aiming for mastery, we need to know the specific job description for the 4 most critical ones released right at the start.
Absolutely. Think of them as the initial 4 signals that launch the whole repair mission. First, you have platelet-derived growth factor, or PDGF. This is the recruiter. Its main job is chemotaxis. It calls in the fibroblasts and smooth muscle cells.
Okay, PDGF is the recruiter. What's next?
Then you have transforming growth factor beta, or TGF-β. This is the structural engineer. It's essential for depositing and regulating the extracellular matrix.
So it's in charge of the building materials.
Right. Third is epidermal growth factor, EGF. This is the skin surface man. Its job is to drive epithelialization, getting that new protective layer in place. And finally, vascular endothelial growth factor, VEGF. This is the utility foreman. It's the primary signal for angiogenesis, making sure a new blood supply gets built.
So in that first instant, the body stops the bleeding and immediately sends out the chemical alarms to bring in all the different construction crews. And the physical result is the clot.
And that clot is so much more than just a plug. It's a provisional matrix. It's a biological scaffold made of fibrin and fibronectin. It provides the sticky framework that all the other cells, the macrophages, neutrophils, fibroblasts, will crawl along later.
And at the same time, this injury launches 4 interconnected cascades that kick off the inflammation.
Yes, you get the clotting cascade for fibrin, the complement cascade for chemotaxis, the kinin cascade, which causes pain, and plasmin generation to eventually break the clot down. And all of these release vasoactive mediators, which cause vasodilation and increased permeability.
Which lets the first wave of immune cells get out of the bloodstream and into the wound.
Exactly. Which brings us to phase 2.
Phase 2. Inflammation, the cleanup and triage phase. This lasts up to about 4 days and is really divided into 2 parts based on who arrives first.
Correct. Early inflammation, days 1 to 2, is the neutrophil phase. These are the shock troops. They are the first specialized immune cells on scene, recruited within 24 to 48 hours.
And what's drawing them in so fast?
Potent chemoattractants. Things like activated complement, bacterial peptides, little fragments of the ECM that were broken during the injury, and that early TGF-β.
And getting from the blood to the wound site is a 2-step process.
It is. First, they have to stick to the endothelial cells lining the blood vessels. That's called margination. Then they have to squeeze themselves through the vessel wall into the tissue, which is diapedesis.
So once they arrive, what's their main job?
Their primary directive is sterilization and initial cleanup. They perform phagocytosis, literally eating bacteria and debris. They also release powerful proteolytic enzymes to digest material, and they generate oxygen-free radicals through the myeloporoperoxidase pathway.
Which is like the body's internal bleach.
It's a perfect description. It sterilizes the wound. Their activity is intense, but it's short-lived. They peak and start dying off within a couple of days.
And as the neutrophils wane, the second wave arrives. This is the late inflammation phase from day 2 to 3, and this is the macrophage phase.
Yes, monocytes are the precursors in the blood. They're attracted by a cocktail of signals, including the breakdown products the neutrophils just created. Once they get into the tissue, they differentiate into macrophages. And in the context of wound healing, these are arguably the most important cell type of the whole early process.
Why are they so critical? They're great cleaners, but what else do they do?
They are the project managers of the next phase. Beyond just cleaning up dead neutrophils and leftover debris, they release the comprehensive cocktail of cytokines that launches the entire construction process. They're the ones who flip the switch from destruction mode to building mode.
So let's list some of those cytokines they release.
Well, they release more of the same recruiters like PDGF to call in more help. They release structural stimulators like TGF-β, and they release signals that promote the growth of the new skin cover, like TGF-alpha, and signals that encourage vascular growth, like fibroblast growth factor, or FGF.
There's a really profound clinical insight here. If you eliminate the macrophages, healing just fails. What does that tell us about their role?
It confirms they are the central orchestrators. If you have macrophage depletion, you get a cascade of failures. Poor debridement, delayed fibroblast proliferation, delayed ECM synthesis, no angiogenesis, and poor fibrosis. You simply cannot start building without the macrophage project managers clearing the site and providing the blueprints.
Okay, so that brings us to phase 3, proliferation, the big construction phase. This kicks off around day 3 and can run for up to 4 weeks.
And it involves 4 highly integrated processes that are all happening at once.
Let's start with re-epithelialization, restoring that skin barrier.
Right. This is the replication and the directed movement of epidermal cells to rebuild a proper keratinized, stratified squamous epithelium. And the cell division, the mitotic activity, starts incredibly fast within 12 hours of the injury.
How do the cells actually move across the gap?
Initially, a very delicate covering called epibole forms. The cells migrate as a sheet by extending these temporary foot-like protrusions called lamellipodia. They literally pull themselves across the moist wound bed.
And the environment here matters a lot. What conditions make this process faster?
It's most rapid under hyperbaric conditions, so high oxygen delivery, which just highlights the huge metabolic demand on these cells.
And what stops them? How do they know when the job is done?
That's a mechanism called contact inhibition. When the sheets of migrating cells meet in the middle, they stop moving. This restores the continuous barrier, which is crucial for locking out pathogens.
Okay, next up in proliferation is the physical core of the repair, granulation tissue formation.
This involves two things: fibroplasia and ECM production. Fibroplasia is just the recruitment and proliferation of fibroblasts, the main building cells. They arrive 2 to 4 days after injury, called in by that PDGF and TGF-β we talked about.
And once they're there, they start making the extracellular matrix.
Yes, they start secreting the structural proteins like collagen and elastin, and also the interstitial matrix components like fibronectin, which is like a cell-binding glue, and hyaluronin and proteoglycans, which provide hydration and bulk.
Collagen is the key for strength.
Yeah.
What type do they lay down first?
This is a critical point. Initially, they lay down collagen type 3. It peaks around 5 to 7 days. This type 3 is laid down fast, but it's disorganized and relatively weak. It's the initial scaffold, which will get replaced later by the much stronger type I collagen during remodeling.
The third process is wound contraction, driven by those myofibroblasts we mentioned.
Right. Contraction starts around day 7, peaks at 2 weeks, and it's highly efficient. It can shrink the defect at a rate of about 0.6 to 0.7 millimeters per day.
And you said this is driven by fibroblasts that transform?
They undergo a phenotypic alteration. They change their characteristics and gain contractile filaments, just like smooth muscle cells. And this change is driven by the mechanical tension in the wound and by PDGF.
But the regulation of this is vital. You don't want too much contraction.
That's a real double-edged sword.
Yeah.
It's essential for minimizing the final scar, but if it's excessive, especially over a joint, it causes those severe functional contractures.
And the final part of proliferation, angiogenesis, getting a blood supply to the new tissue.
This starts early, around day 2 or 3, and it's absolutely essential to supply the massive metabolic needs of the healing wound. In fact, that red granular appearance of granulation tissue is because it's made of proliferating fibroblasts and tons of new, immature capillary loops.
So how does a new blood vessel actually form?
It's a 4-step process. First, you degrade the parent vessel's basement membrane. Second, the endothelial cells migrate toward the signals VEGF, PDGF, FGF. Third, they proliferate like crazy. And fourth, they mature into functional capillary tubes.
The clinical takeaway seems obvious. No blood, no healing.
Absolutely. Insufficient vascular supply means the whole process stalls, and that's when you get a chronic wound.
Which leads us to the final longest phase. Phase 4, remodeling and scar maturation.
This phase overlaps heavily with proliferation. It starts around week 1 and can go on for many, many months. This is where that initial rushed scaffold gets replaced by a mature, stronger structure.
And it's all about a delicate balance, right? Building new collagen while breaking down the old messy stuff.
Exactly. This cycle is mediated by a family of enzymes called metalloproteinases. These include collagenases, which break down collagen, and they're made by fibroblasts, neutrophils, and macrophages. They're the demolition crew.
So how does the body control them so they don't just destroy everything?
Regulation is everything. They are synthesized in an inactive state, and their activity is tightly controlled by inhibitors called tissue inhibitors of metalloproteinases, or TIMPs. This system ensures a controlled breakdown, allowing the weak type 3 collagen to be systematically replaced by the stronger, more organized collagen type 1.
When does the wound really achieve its final stability?
The equilibrium between formation and degradation is usually reached around 21 days. After that, continued remodeling reduces the cellularity and vascularity, and the scar transforms from red and raised to pale and flat.
And let's reemphasize that final crucial limitation. This is a biological fact everyone needs to remember.
The reality is, the collagen in a scar will never reach the strength of unwounded skin. Because of the difference in fiber structure, it achieves a maximum of only 80% of the original tensile strength. That 20% deficit is the price of repair.
So we've really mastered soft tissue. But what happens when the injury goes deeper, when the underlying structure, the bone, is involved? It must follow a similar rhythm, but with a critical added component.
The initial steps are pretty much identical to soft tissue. You get the immediate hemorrhage, the clot, the inflammatory response with neutrophils and macrophages, all releasing those same foundational growth
But
factors.
at some point, the body has to switch from making fibroblasts to making osteoblasts, the bone-forming cells.
Hmm.
What are the specialized chemical signals that make that happen?
We call them osteogenic cytokines. TGF-β is still essential. It calls in the osteoprogenitor cells. Then you have tumor necrosis factor alpha, or TNF-alpha. This is critical for recruiting the early mesenchymal stem cells. In fact, if TNF-alpha is absent, bone formation is completely prohibited.
Wow, so it's a non-starter without it.
Completely. And then you have the master regulators, the bone morphogenic proteins, or BMPs. These are the ones that really govern the growth and differentiation of osteoblasts and chondroblasts. They are the specific blueprints for bone.
Okay, so after the inflammation and cleanup phase, the soft tissue clot is replaced by something else.
Right. The debris and dead bone fragments are cleared by osteoclasts and macrophages, and granulation tissue fills the space. Then the bone-building cells, the osteoblasts, arrive. They're provided by the surrounding vascular endothelial cells and mesenchymal cells.
And this leads to the formation of the soft callus.
Yes, and this stage is really governed by the local environment. Osteoblasts release calcium, but if the oxygen tension at the fracture site is low, the chondroblasts, the cartilage-forming cells, become highly active.
So the soft callus is a mix of new calcium and flexible cartilage.
Exactly. It's flexible, which is why you need to immobilize a fracture, but it provides that crucial initial stability.
And the final transformation into hard bone.
That's maturation. It's a continuous process of superiosteal and endochondral ossification, where the cartilage is systematically replaced by bone. This hard callus usually unites the bone ends after about 2 months. Then, remodeling begins, where osteoblasts and osteoclasts work together to restore the original contour and reestablish the marrow cavity.
It's incredible that bone can truly regenerate without a scar.
It is, but the process is highly sensitive to external forces. Weight-bearing and mechanical stress actually alter the remodeling process, ensuring the new bone matrix is aligned to withstand future loads. That's why rehabilitation is so critical.
Okay, so for surgical success, understanding the normal cascade is only half the battle. We have to recognize the factors that act as roadblocks to healing.
Absolutely. This is the true clinical challenge, recognizing the myriad of factors, both systemic and local, that can completely derail the process.
Let's start with the systemic factors, the things that affect the entire body.
Age is a huge one. As patients get older, their bodies accumulate issues that impair every single phase of healing. They show delayed epithelialization, altered inflammatory profiles, impaired angiogenesis, and reduced granulation. And their existing collagen is already reduced, so their final tensile strength is even lower than that 80% we talked about.
Next is the fuel for the whole process, nutritional status.
Right. You can't rebuild if you don't have the raw materials. Protein-calorie malnutrition severely delays healing. We use a few markers to assess this, and the key is understanding what they represent in terms of time.
So what are the markers?
Well, you have serum albumin. It has a long half-life, so it reflects long-term status. It's useful but slow to change. Then there's serum transferrin, which is also useful but is affected by the body's iron status.
Which one is the most useful for an immediate risk assessment on the ward?
That would be prealbumin. It has a much shorter half-life, making it the best, fastest indicator of acute malnutrition and immediate poor healing risk. Clinically, you should be using screening tools like the Malnutrition Universal Screening Tool, or MUS, to identify high-risk patients who need support before surgery.
Okay, let's talk about underlying chronic conditions, and let's focus on the biggest one. Diabetes mellitus. Diabetes just creates a hostile environment for repair.
It's a profound, multifactorial failure. You can really group the mechanisms into 3 areas, all driven by high glucose. First, impaired diffusion. High glucose increases vascular permeability, which creates a barrier that blocks oxygen and nutrients from getting to the wound.
So it starves the wound.
It starves the womb. Second, structural damage. Sugar molecules irreversibly bind to proteins, a process called non-enzymatic glycylation. This inhibits the function of everything. And third, remodeling failure. Glycosylated collagen is resistant to being broken down, so the body can't clear out the old type 3 framework.
And the outcome is just a total shutdown of the proliferation phase.
Precisely. Diabetic wounds show decreased granulation, decreased collagen, slow maturation, and fewer fibroblasts. They are just prone to becoming chronic, non-healing ulcers.
And finally, we have to look at a patient's medications.
Yes, steroids are notorious. They arrest the inflammatory phase by interfering with macrophages. Non-steroidal anti-inflammatory drugs, or NSAIDs, reduce collagen synthesis. And many common chemotherapeutic agents directly reduce fibroblast proliferation and wound contraction.
So those are the systemic factors. What about local problems right at the wound site?
These include things like poor blood supply, high skin tension, a foreign body in the wound, poor venous drainage, underlying bone infection or osteomyelitis, and critically, infection.
Let's zoom in on infection. There's a specific bacterial threshold that determines if healing can even happen, right?
There is. An infection traps the wound indefinitely in the inflammatory phase, and the critical threshold is traditionally known. If the bacterial count gets above 10 to the power of 5 bacteria per gram of tissue, or if something aggressive like beta hemolytic streptococcus is present, the wound will simply not progress.
The building crew just can't work on a site that's still an active war zone.
A perfect way to put it. The perpetual inflammation inhibits epithelialization, contraction, and collagen deposition.
Okay, now let's flip to the other side of the spectrum. Excessive wound healing or aberrant scarring.
This represents a total loss of the off switch in the remodeling phase. It's driven by an overproduction of fibroblasts, collagen, and all the other matrix components. It happens in about 5 to 15% of wounds, and it's much more common in individuals with pigmented skin.
And how do we differentiate the two main types? What's the anatomical difference between a hypertrophic scar and a keloid?
A hypertrophic scar respects the original wound boundary. It stays strictly confined to the borders of the original injury. It might be raised in red, but it doesn't invade surrounding tissue.
And the keloid.
The keloid is a benign but fibroproliferative scar that grows beyond the confines of the original wound. It actively invades the surrounding healthy tissue. It has a strong genetic link, and fascinatingly, the size of the initial injury often has no correlation to the size of the final keloid. The body just lacks the signal to stop.
Okay, so let's synthesize all this biological knowledge into practical clinical decision-making. Let's bring it from the microscope to the bedside. To manage a wound, we need a logical progression. Classify it, assess it, and then apply a management strategy.
Right. And we can start by classifying wounds based on their duration, acute versus chronic. Acute wounds from trauma or surgery usually heal well. Chronic wounds, which persist beyond 6 weeks, are a huge red flag that there's an underlying physiological failure.
And they carry a specific risk of malignant change.
They do. The development of a Marjolins ulcer, which is a malignant transformation within the chronic wound bed. It requires aggressive surgical intervention.
For acute wounds, let's quickly touch on the 4 surgical contamination classes.
Yeah.
This is a critical tool for predicting infection risk.
Right. It ranges from Class 1, clean, which is an aseptic procedure with minimal risk, all the way to Class 4, dirty infected, which involves pre-existing infection or devitalized tissue and has the highest risk. Classes 2 and 3 fall in between with increasing degrees of contamination.
But the majority of chronic management focuses on what you could call the 4 ulcers: diabetic, pressure, venous, and arterial. Mastery here means being able to tell them apart instantly.
Absolutely. And you can do that based on location and appearance. Diabetic ulcers are from neuropathy, so they are over pressure points. The hallux, metatarsal heads, the heel, they look painless and deep.
Pressure ulcers are over bony prominences from unrelieved pressure. Sacrum, heels, elbows.
Correct. Venous ulcers are the most common. The key is location, around the medial malleolus or inner ankle. They tend to be shallow, large, and have irregular edges, with a slothy base that might have some pink granulation tissue.
And arterial ulcers?
They're from a lack of blood flow or ischemia, so they're on the lateral malleolus, the outer ankle, or the tips of the toes. They look small, deep, with a punched-out appearance. And critically, because there's no oxygen, they have no granulation tissue, and they're usually extremely painful.
So when you're assessing a wound bed, you need to be able to read the tissue types present. This tells you what biological phase the wound is in.
Exactly. You're looking for 4 things. Granulation tissue is the good stuff. Red, moist, shiny, granular. That's the proliferation phase in action. Epithelial tissue is that pale pink or white tissue creeping in from the edges.
Then you have the non-viable necrotic tissue.
Which comes in 2 forms. Slough is the moist, stringy, yellow stuff, debris waiting to be cleared. Eschar is the dry, thick, leathery black tissue like you see after a full-thickness burn. It often needs to be surgically cut out.
And finally, infected tissue.
Identified by the classic features: pyrexia or fever, pus, spreading erythema, a bad smell or malodor, dehiscence, and increased pain. If you suspect it, you need a wound swab for culture. And remember that threshold, more than 10 to the power of 5 bacteria per gram of tissue, and it's not going to heal.
The edges of a chronic ulcer are also really diagnostic. What should we look for there?
Sloping edges are typical for venous ulcers. That sharp, well-demarcated, punched-out look screams arterial disease. And most critically, if the edges look rolled or everted, piled up, you have to rule out malignancy with a biopsy immediately.
Okay, so let's talk about wound management and dressings. The goal of modern wound care is to sustain a moist wound environment, right?
Yes, a moist environment supports cell migration, enzymatic debridement, and reduces pain. Dressings are the tools we use to achieve that. And the key is matching the dressing's function to the tissue type.
So let's run through the strategy. What do you do for a necrotic wound covered in Escher?
The aim is usually to rehydrate it. You use moisture-donating dressings like hydrogels or hydrocolloids to encourage natural autolytic debridement. If it's extensive, though, you need prompt surgical debridement.
For a slewy wound.
Here, you want to absorb the debris and exudate, so you use things like hydrofibers or alginates that soak up that inflammatory matrix and form a gel.
And for a healthy, granulating wound.
The priority is just to maintain that moisture. You choose based on how much it's weeping. Hydrocolloids or foams for light exudate. For deep cavities, you might use alginate ribbons or even escalate to vacuum-assisted closure, or VAC therapy, which uses negative pressure to promote contraction and granulation.
What about epithelializing wounds?
Those are superficial. They just need non-adherent protection. A simple paraffin gauze or a thin film dressing is often enough.
And finally, infected wounds.
They must be covered, and you have to reduce the bacterial load, so you turn to dressings that contain antibacterial agents, things with silver, iodine, chlorhexidine, or even medical-grade honey. The goal is to get the wound out of that perpetual inflammatory phase.
We've completed a pretty comprehensive journey today, diving deep into the fundamental mechanisms that govern repair.
We really have. We tracked the whole choreography, from the immediate clot and the cleanup crew of neutrophils and macrophages, all the way to the construction phase with fibroblasts, angiogenesis, and the action of the myofibroblasts.
And we highlighted that profound difference between soft tissue, which ends in an 80% strength scar, and hard tissue like bone, which uses signals like BMPs to achieve true regeneration.
The key takeaway for you, the professional learner, is really understanding the balance and the limits of natural healing. That 80% strength cap is a hard limit. Mastery lies in regulating contraction, managing inflammation, and ensuring that delicate equilibrium between collagen synthesis and degradation.
Looking ahead, the future of medicine is really trying to push past these natural limits. We're seeing intense research into applying topical growth factors directly to wounds. There's even work in gene therapy using vectors to insert human growth factor genes into wound cells.
And we're exploring the use of mesenchymal stem cells, which can differentiate into multiple tissue types and enhance healing. There's also fascinating research into electrical stimulation ES, which has been shown to accelerate repair by reducing inflammation and increasing angiogenesis.
All of these are trying to close that last 20% gap in strength and organization. And that brings us to our final provocative thought. We know the natural scar only ever achieves 80% of the original tissue strength. Given these advances, topical agents, gene therapy, electrical stimulation, is reaching 100% strength or maybe even achieving true scarless regeneration, a realistic goal for the future of medicine. What is the biological limit of human tissue repair?
A question that really defines the boundaries of the field, something to ponder as you reflect on all these complexities.
Thank you for joining us for this deep dive. We'll see you next time.